Okay, so let's dive right into Early Pregnancy Pearls Part 1. So today we sort of have a little bit of a saga of pregnancy. In the morning you get Part 1, and in the afternoon you're going to get Part 2. So evaluating a pregnant patient always adds a little bit of stress. And why is that? Because there's two patients. Yeah, that's exactly right. There's two patients. So you have to not only think about what's good for mom, you have to think about what's good for baby. So there's some special considerations, and between these two chapters, we actually go through a lot of the really controversial stuff about dealing with the pregnant patient. We're not going to do anything simple here. It's all going to be controversial, hopefully worthy of some discussion. You guys can jump in with questions, with stories, with whatever you want at any point in time. I definitely don't mind being interrupted. So, question number 1. This is a relatively important question. Is this patient pregnant? I think that's a good place to start. So I know nobody's ever seen this case before, but I'm going to describe a really weird case I had. It was this lady who came in with abdominal pain, and I said, is there any possibility you can be pregnant? And she said, no way, no chance. Never had sex before, virgin, impossible. I cannot be pregnant. Can't happen. And she was pregnant. Anybody ever seen that? Crazy case? Yeah, totally unheard of, I know. So this whole section is kind of talking about that issue of how reliable are patients in telling us that they're pregnant and how good are we at judging. You know, we sort of have this dictum. I work at LA County, USC Hospital. We sort of have this dictum that anyone between ages 8 and 80 gets a pregnancy test. Now, it seems a little extreme, but that's actually what we say. I'm not going to say that's what we do on a day-to-day basis, but that's definitely what we say. So abstract number 1 is basically, it's kind of a weird little study. It's a German report, cases of women who didn't know they were pregnant until over 20 weeks of gestation. So this is pretty far along in their pregnancy. And they're saying, you can just take this number and put it in your head that 1 out of 500 women is not going to know they're pregnant until they're 20 weeks pregnant. How much reliability do you put in that number? None at all, right? But it's just to introduce a concept that this is not totally unheard of. But we all know this from our clinical practice anyway. Just so you know, it's not included in the abstracts, but it was covered in the course last year, that there are 2 new CMS quality measures that everybody does need to be aware of regarding pregnant women, and they are as follows. Number 1, it's measure 253. A pregnancy test must be done and documented in the chart for every female with abdominal pain between the ages of 14 and 50. Right? So this is a CMS quality measure, which is new, 2012. Measure 254. If the patient is pregnant and has abdominal pain, before they leave the emergency department, they must have a documented ultrasound showing the location of the pregnancy. Right? Now, this does not need to be done in the department. If this is a patient, for example, who has an OB and has already seen them and has a documented IUP, you can just put that in your note, that they have a documented intrauterine pregnancy. But these are 2 CMS quality measures that everybody needs to be made aware of. So the way CMS does this stuff is all via chart review, right? It's very complicated how they look back and actually decide how many of these things we are being compliant with. As long as it's documented, if the patient says that they have an IUP and you document it in there, there are 2 questions. One is, how appropriate is this from a medical perspective? And that's up to you. That's your personal threshold. But from a CMS perspective, it's fine. It just needs to be documented somewhere in there that you asked or you looked and they've had an ultrasound showing an IUP. Measure 254, ultrasound determination of pregnancy location for pregnant patients with abdominal pain. I don't have the whole measure here. That's the title. You can look it up. Google it. It's online. So, abstract number 2. What they did then was they said, okay, let's take a look and see how well are we actually following these measures generally. And this is an interesting abstract. So what they did was they took the NAMCs database. Now this is a huge nationwide sample of emergency departments. And they looked at women between ages 14 and 50 and said how many of them had a documented pregnancy test of those that came in with abdominal pain. And what they found in this NAMCs chart review was that only 1/3 had a documented pregnancy test. That's kind of on the low side of things, I would say. But what's weirder is in patients who had a diagnosis, A diagnosis, an ED diagnosis of ectopic pregnancy, what percentage of those had a pregnancy test? 50, right? So what does this tell us? What this tells us is even the most well-vetted national databases are not perfect, right? These things make mistakes. They're all chart reviews. So what they did then was they did a local review of some of the same charts that had been reviewed by NAMCs, and what they found was that 94% of eligible patients had a documented pregnancy test. So it just goes to show you that in the spirit of these abstracts and being hypercritical of the literature and things like that, even the large databases have problems when you're looking for something very specific. Abstract number 3 is kind of a fun one. It's basically about how much can we trust patients and trust ourselves. They took almost 400 emergency department patients, females of childbearing age, and they asked them to just say, hey, are you pregnant? What do you think? No chance at all, maybe a little bit of a chance, moderate chance, high chance, or I'm definitely pregnant, right? And then they let the physician go in and do their exam and their history, and they ask them the same questions. What do you think? Based on what you talked to this patient, no chance, some chance, moderate chance, definitely pregnant. What do you think they found? It's a little, it's about, I think it's pretty consistent with what we'd find in real life. In the group where the patient said, there is 0% chance I'm pregnant, none of them were pregnant. In the group where the doctor said, absolutely no way, no chance, patient denies it, nothing that goes history, I believe them, they said they're not pregnant, there were no pregnancies. So this is kind of reassuring in that generally we can trust our patients. The funnier part of the study was on the flip side, where when the patient said, I am definitely 100% pregnant, only 9 out of 10 were actually pregnant. So is this totally relevant in the area where CMS says we have to document a pregnancy test in all these patients anyway? Probably not, but it's just nice to know that we can trust our patients for the most part. They are giving us accurate information as best as they can to help us in our diagnostic process. So the next 2 abstracts change gears completely and look at medication usage in potentially pregnant patients. So abstract number 4 is a chart review of almost 500,000 patients. Huge. And what they looked at was women who came into the emergency department of childbearing age and got some kind of a prescription to go home with. And what they found was that 1 out of 6 women got a potentially teratogenic medication of the medications that they got sent home with. And what the point they were trying to make here is not that we should never give a woman of childbearing age a potentially teratogenic medication, because that list is huge and it's medications we use all the time. It's that if we are going to give them a medication, we shouldn't totally rely on the pharmacist. We should say like, hey, if you think you may be getting pregnant or trying to get pregnant or whatever, let me know, because that could influence the antibiotic I give you or whatever medication it is that I give you. But abstract number 5 is one where they're looking at mothers. It's a statewide database of 15 years. They looked at 30,000 patients with 30,000 controls, and these are mothers who were given ACE inhibitors during their first trimester of pregnancy. And what they found was that in the group that got ACE inhibitors, there was a 3 to 4-fold increase of major badness with baby, major cardiac problems, major CNS problems. We know ACE inhibitors to be highly teratogenic medications. Now, how many people here have started an ACE inhibitor from the emergency department? Basically nobody. That's about what I thought. But I think that this paper is still really relevant, because how many people here have diagnosed a new pregnancy in the emergency department? Right? That's everybody. So we need to know about these kinds of things. If we diagnose a new pregnancy in the emergency department and the patient otherwise looks fine, typically what's going to be happen is there's going to be a relatively long delay until they finally see OB, right? It's not going to be like the next day. It's going to be several weeks. So I think that my little take home from this section is if you do diagnose a new pregnancy, it's not something we do often, but it may be worth taking a quick look at their med list to see if there's any highly teratogenic medications on there that we could potentially take them off of. And I think that's not something that at least is in my routine practice. It's something I need to be reminded of. So the next question, what are issues related to nausea and vomiting in early pregnancy? I'm going to sort of summarize this in a little bit more of a lecture format than going through the abstracts. First recommendation, if a woman comes in with nausea, vomiting in early pregnancy, would be dietary recommendations. So they say do more frequent small meals, eat a little bit before you get hungry, choose carbs over protein. Women with early nausea, vomiting, and pregnancy tend to do better with carbs. Avoid spicy, fatty foods. And one of the official recommendations is for peppermint tea. Does anyone have any personal or patient experience with using peppermint tea for nausea and vomiting, pregnancy? I don't. I certainly don't have any personal experience, but anyway, okay. So those are dietary changes, and then there's non-pharmacologic interventions. So this is just sort of avoidance of triggers. So there are certain triggers that make women pregnant. It could be smoking, it could be a certain perfume or odor, it could be a pet. Just have them avoid those things generally. And then there's this whole category of alternative therapies with acupuncture and acupressure being one of them. So how many people have seen those wristbands, those little things with a little ball that go like sort of on your wrist, acupressure? So they've studied those a bunch of those times, and how well do they work? They work really well at making somebody super rich for not doing anything, I don't believe. I don't think that they've ever been shown to work, this acupressure thing, but still, some people, there is a placebo effect, so it's possible that your patient may like this. Drugs, what about drugs? Most drugs in pregnancy are very safe and very effective, and we'll go through some of the better choices of drugs. So what are the two big Class B medications for nausea and vomiting in pregnancy? Zofran is one, and what's the other? Reglan. So Reglan and or Zofran should be your first line go-to for nausea and vomiting in pregnancy. Some of the other ones we use more commonly, like Phenergan, Compazine, and stuff, just so you know, are Class C. So your first line should be the Zofran and the Reglan. And the last thing, which there's actually an abstract about this, is ginger. That gets its own little category in terms of recommendations for the pregnant patient with nausea and vomiting. So then quickly going through these abstracts, abstract number 6 is basically a very well-written review on some of the topics that I just discussed, sort of the dietary changes, the alternative ways to deal with these patients, etc. One thing they remind us of, which is critically important, is that nausea and vomiting of pregnancy that starts after 20 weeks is not nausea and vomiting of pregnancy. Okay, this has to be in your head, this cutoff. Early on, women get nauseous. That's okay. If they've been fine their whole pregnancy, they come in at 24 weeks, and they all of a sudden have new nausea and vomiting, don't just say, you're pregnant, pregnant people get nauseous, don't worry about it. Nausea and vomiting after 20 weeks of pregnancy has to be taken seriously, and you have to find a medical reason for that, and they may even necessitate admission to the hospital even if you can't find it. Abstract number 7 basically just is similar to number 6, except it lists out a bunch of those different causes of what could be happening after 20 weeks, and it's nothing that you couldn't come up on your own. This is not a magical list. It's like GI things, UTIs, some kind of psychiatric disorder. There's a huge list, a differential diagnosis they go through, which we would go through with anybody with nausea and vomiting. It's nothing special. Abstract number 8 just looks at the different antiemetics, essentially saying that they're all safe. The one take-home message from this abstract, which I think is important, is that if one antiemetic is not working, using a combination of two has a more than additive effect. So if you're giving somebody Zofran and they're still puking in the department, even though you're giving them fluids, adding on Reglan could be the thing that makes a huge difference. And it's not a 1+1 thing. Like, it really, really seems to have massive increased efficacy when you use 2 antiemetics as opposed to just 1. Abstract number 9 is the randomized control trial of ginger. It was a 3-week course of ginger versus vitamin B6, which was their active control. And they found basically that in the active control group, about half the women got better, and in the ginger group, half the women got better. So it didn't do much better than just vitamin B6. Anybody here either tried using ginger when they were pregnant or told a patient about it? It's pretty common. Like, most patients seem to think that ginger really works. And what I would say in my head, I would use that as if you have a patient who is highly anti-medication, you know, those women who like say, you know, I don't want to put anything in my body, I don't want to hurt the baby, I don't want to take any chances, I know you're saying it's safe, then you might say, well, try some ginger. There's maybe a 50% chance that it'll work. So it can sort of be last line. And abstracts number 10 or 11 are basically the same. They're both just looking at Reglan and saying that using Reglan is very safe during pregnancy, even when they follow these kids out after birth.
How do you tell
What's that? I'm sorry? Oh, you can go to any, so the question was, how do you use ginger? If you're going to like prescribe ginger, you go to any sort of whole food style market or vitamin store and you'll find plenty of pills, ginger capsules, and they can just take the capsule or they can drink a ginger tea, which I'm sure is delicious. I like ginger. I don't know if anybody else does. Okay. And then there's only one more question in pregnancy, early pregnancy pearls part 1, but luckily this is a really easy question to answer. We can get through it quick. What is the imaging modality of choice to evaluate pregnant women for pulmonary embolism? So I'll create a situation for you. This is a clinical scenario. This is a 29-year-old female who comes in 14 weeks pregnant, and she presents with shortness of breath, some pleuritic chest pain. She's satting about 89% on the monitor. She has a heart rate of just around 102. She's not tripoding. She's able to speak full sentences, but she says, I really feel short of breath. I just can't catch my breath. And I'm pregnant. So what's the first thing you do? No, you take the chart, you put it back, and you pick up another chart. That's the first thing you do, if that's a possibility, right? Or you say it's too close to the end of your shift. So we'll assume that she's pregnant. We have a confirmed pregnancy. So now we have a situation where we have to deal with ruling out pulmonary embolism in a pregnant patient, right? And this is a complete nightmare. And I'm not going to lie to you, at the end of this particular section, you may still not have the answer of what to do. But what we will have is a good chunk of the data, and then you can make your own decision on what to do. So the first abstract, abstract number 12, is a consensus statement. So this says the official American Thoracic Society of Thoracic Radiology clinical practice guideline, evaluation of suspected pulmonary embolism in pregnancy. This is endorsed by the American College of OB-GYN. So this sounds very official. Let me take an unofficial poll first. That patient we described, how many of you would get a VQ scan on that patient? VQ, to rule out PE. Maybe 4 or 5 in the room. How many would go to CT? Okay, so I will read you the official recommendations. No D-dimer. That's very good. That's a good start because we know it's almost always going to be elevated. Regardless of lower extremity appearance, start with bilateral lower extremity Dopplers, which I think is a good recommendation for a couple of reasons. Because one, if you find one, you're golden. You don't even have to worry about this radiation problem. But two is, it buys you a little bit of time to like stop, think, and maybe go like look up the literature or listen to this lecture again really quickly and remember what you're supposed to do, right? So it does give you a little buying time. Their official recommendation is if ultrasound is negative, get a chest x-ray. If the chest x-ray looks clean, which it almost always does, these are young, healthy, female patients, that you should be getting VQ scans on all these patients and not CTPAs. So this is the official recommendation that's being proposed. Not proposed, but enacted, endorsed by really high up influential societies. How do we feel? How does this sit with us in the stomach? Doesn't sit very well with me personally, you know, because I've always been taught that a CTPA is more radiation to mom and less radiation to baby. And a VQ scan is less radiation to mom, but more radiation to baby. And why is that? It's exactly right, because all that ionizing radiation gets all in the bladder, right next to where baby lives, and he just sits there getting exposed to radiation. Now, so how do they come up with this recommendation? What do they say? What they say is, oh, well, there's an easy way to eliminate that problem. What you do is you like put a Foley in there, you empty out the bladder. While you're doing the VQ scan, you have the Foley attached to like suction or something so like nothing could ever stay in the bladder for more than 2 seconds. Like it's completely ridiculous, right? But just so you know, there is a guideline and that's what it says. But now, if you look at some of these abstracts, so abstract 13 is basically just looking at different types of radiologic studies for different conditions in pregnancy. For API, they're saying if you have a pregnant patient with API, what's your imaging modality of choice? First line? Ultrasound, exactly right. And if that's negative, MR would be the official recommendation for a second line. PE These particular authors, and this is a group, an evidence-based group out of UC San Francisco, say definitely CTPA is the way to go. It is not VQ scan for the very reason that we discussed. And then colicky pain, they say ultrasound, and trauma, essentially they say avoid CT unless the patient is really, really sick. Just don't do it. Abstract number 14 reminds us that exactly what we said before. This is another group of authors. This is from 2006, and they say definitely CTPA is the answer. It is not VQ scan for the same reason we just talked about. Way too much radiation for baby. And also, the thing they don't mention in any of these things is one of the reasons I don't like ordering a VQ scan is because it sucks to order a VQ scan. Right? There's like no way to get anyone to do this freaking test that we're supposed to be able to get very easily. Oh, this is official recommendation for a test. I'm sure that test is really easy to get in my department, but it isn't. It never is. It's always a pain. So that's another thing they don't mention. They don't mention the pain in the ass component, but I think we all know it exists. It is real. Abstract number 15 is a chart review of 300 women who got either CTPA or VQ. In this particular sample, most of them ended up getting a VQ scan. Kind of irrelevant. This is just their hospital. It's their experience. The only important thing here is that what was the incidence? What was the positive rate in these 300 patients who got some form of workup for PE? In this study, 6%. So we had a 6% rate. That is really, really low. So this is a highly controversial area of what to do. We know we're doing, on some level, we're doing something bad. Any radiation to baby is not good, right? Now, we can debate which one is the less gooder, or whatever the right word is, but it's definitely bad. So the point here, I think, is before you even open this can of worms, before you really go down this path, make sure that you want to be thinking about PE in this patient. Abstract number 16 is looking at basically just saying, comparing the two in terms of non-diagnostic scans, but it's a retrospective study. They're looking at some patients who got CT and some who got VQ, and they're saying, the group who got CT, a little bit more non-diagnostic scans, maybe we should be relying on VQs, but they don't have any methods listed. They don't have any reasons why the patients got a CT versus a VQ scan, so this abstract number 16 is pretty useless. Let me just get to the last one here, and then I'll take questions. Abstract number 17, pulmonary embolism in pregnancy, CTPA versus perfusion scanning. Again, this is a group about 100 women who got CTPAs and a group of 100 women who got VQ scans. The findings, in my mind, relatively irrelevant, but what they want to point out, what I pointed out before, is their incidence in this study of a positive test, regardless of modality, was 2%. Right? Their point being, again, we're getting a little trigger happy. Right? We're over-testing patients for PE in pregnancy. Every little shortness of breath, we freak out about it. Right? So this is one thing to really, really remember, very important. Like I said, it's highly controversial which test to get. I personally get CTPA. So if you want my opinion, that's what I would do. Not only because it's easier, but because I honestly believe in my heart that it's a safer test for the baby. I really do. And I think that if you have this discussion with mom, and you explain to them one test is going to be a little more dangerous for you and one test is going to be a little more dangerous for baby, I don't even think they'll let you finish the sentence for the most part, right? And they'll choose the test that's a little bit safer for baby. So I personally go with CTPA, which is not what the guidelines say, and I'm happy to take any questions. Sounds like there's already one in the front.
Did you try any MR protocols for PE?
So the question was, have we tried any MR protocols for PE? We have not. Has anybody here used an MR protocol for PE in their department? Can speak to that? You have?
Yes, we have a new attending. She's over several months ago.
A new radiology attending?
No, they didn't.
A new ER attending?
Apparently there is an MR protocol where you can protocol so you can diagnose PE. It's not very sensitive, and the problem is not putting vomit.
Right. Yeah, so he was saying they have a new ED attending who is into this MR for PE, and my understanding generally is that MR for PE is not that sensitive, and we need a very sensitive test for PE, like if we're going to do something, because if it comes back non-diagnostic, all we did was waste a bunch of money and a bunch of time. That would be my opinion, but as far as I know, there's been no studies done on MR for rule out PE in pregnancy specifically. I don't think there has been any. Okay.
Right? You'd probably assume that of those people that had PEs, half at least selected out so many that now your incidence is really low.
But it should be, so the question was, is it possible you've sort of selected out people who you wouldn't have scanned anyway if they were not pregnant? But I think it's actually the reverse, right? Because in theory, all of these patients should have gotten, now they didn't say if they did or not, but they should have gotten bilateral lower extremity Dopplers before getting one of these two tests.
Right, that's what I'm saying. You just pulled out a bunch of positives.
I don't think so. I don't know how many positives you get when you screen asymptomatic legs for DVT.
It wasn't asymptomatic, though.
What's that?
I mean, the scenario we're talking about isn't asymptomatic. There were enough positives that people decided to go walk down the road of PE.
My case scenario I started out with was definitely not a kind of a case scenario. It was a hypoxic lady. They didn't really give a lot of the stats on what these patients look like, if they were tachycardic, if they were hypoxic. So I don't know if they really should have been going down the PE road or not. I mean, the numbers would say they definitely shouldn't. An incidence of 2% positive rate for a dangerous test is too high regardless of what your pretest probability is. Like, there is some mistake being made here for sure. And I can say, I personally, like, I'm guilty. I'm as guilty as everybody in this room of overthinking about PE when a pregnant patient comes in with shortness of breath. Like, I don't even need these numbers to tell me that. Like, I know from my own practice that I do it.
But then why not do a D-dimer? Because I know there
Because it's always going to be positive.
But is it always? I mean, what if it's 10% that it's negative? Then you're out of dodge. On 10% of them, you saved them going down that road.
First of all, that would be, if it was a true negative, the true negative rate of D-dimer in pregnancy is not 10%. It's much lower. If it was 10 or 20%, it would be part of the recommendations. We're talking about 98, 99% of pregnancies being positive. So now let's say we have a 1 out of 100 chance where it gets us out of the road. Your false negative rate, you also have to take into account with D-dimer. So now you're talking about a point-something% chance of it being negative, but then you take the flip side of that, where you say like, I'm just not sure, hopefully it'll be negative, and you had like mentally convinced yourself, you talked to her more, and just, I've been exercising, I feel short of breath, and you come back with a positive D-dimer, now you're totally screwed, right, by sending that test, because now you really do have to chase it.
There's people that agree with him. I just heard a lecture on pulmonary embolism, but they talked about pregnant women, and he said that you're doing blood work anyway, you're going to get ultrasounds of the legs. If there's just a lot of time being spent on the front end. If you get a D-dimer, this particular lecturer who cited a bunch of studies, I can't give you the details, said that if it's negative, you can still use it the same way you do for others. It just lowers your suspicion.
So I don't want to totally get into the next person's time. This is a really interesting discussion. Like I said, all these early pregnancy things are interesting. The question, for those of you who couldn't hear it, was that there was another lecture you attended where you said D-dimer could be part of your diagnostic algorithm, even in the pregnant patient. But my counter to that would be that it all depends on your pretest probability. Right? It has to, because that's the way that D-dimer works, is based on pretest probability. Even in a non-pregnant patient, it shouldn't always be part of your algorithm, right? And we know that it is grossly overused in non-pregnant patients because the chance of it taking your pretest probability to an acceptable miss rate of whatever it is, below 2% in a post-test probability, is only useful on a very select group of patients, even without pregnancy. So just, I can't even conceive how in a very muddy group, it could be useful for me, knowing what I know about the test characteristics of D-dimer. Rick is looking at me like I'm blabbing on too much.
Settled.
Yeah, well, hey, I didn't say these topics were going to be easy. I said they were going to be fun-ish. We still got a couple minutes. I'm allowed to run late and run into Rick's time, I think. Well, he's not like he's the boss or anything. So. Any other questions? Last question.
I think it's not necessarily a question, but I think this is probably one of the times when you actually have to discuss stuff. We always just like to order the test and not have to think about it or talk with patients about it. But like, this is a point where you have to actually talk with your patient and say,
No.
this is what I'm really worried about. The scenario that you put forth with the hypoxic and everything, how often does that happen?
Yeah.
Never. There's pregnant women who come in all the time and they're short of breath, and you say, okay, your ultrasound's negative. It's probably really, really, really unlikely that you have this. It's possible, but maybe we should not think about doing the CT scan.
So I think the point that he's making, for the rest of you just to repeat his question, which is this is a good time to involve the patient in the decision-making process. And that's obviously totally ridiculous for anything. We know better than they do in every situation. No, I'm kidding, of course. That's why I mentioned it before. I like to really talk to them about, here's what my understanding, I'm your doctor, this is my understanding of the risks to you based on this test, and the risk to baby based on this test, and this is the risk to you and to baby based on this other test. And here's the risk of not doing the tests at all. And involve them in the decision-making process. I think this is probably a critical time to do that. So an excellent point and a really good way to end this little session. So thank you, and then I'll turn it over to Rick.